Historically, mental health has been a low priority for national policymakers and also for large donors, especially when you look at mental health on a global level and look at what's going on in other developing countries. You tend to see that at the policy level, there's more attention and money spent on communicable diseases rather than on mental illness. Um, but what we are finding as we continue to do research in mental illness is that interventions to treat mental health conditions can also have a positive impact on physical conditions. And that one area where that has proven to be the case is with HIV and AIDS. Another area where mental health treatment can have an impact on an economic and consequence is in relationship to maternal mental health. If we fail to address maternal mental health, which is a relatively cheap expense, then we can have some pretty expensive negative consequences for the infants in those situations that are long-term, lifelong, and chronic. We also have the potential for those who care for people who have mental illness to experience some real financial hardships, end up with some work problems, and so mental illness becomes very expensive when it's left untreated, not just for the person with mental illness, but also for that person's children and that person's caregivers. So a big way to get attention of policymakers is to link mental health issues to money, to economic consequences and outcomes. The World Health Organization has demonstrated that a psychopharmacological approach and counseling combined together are a pretty cost-effective treatment. We also know that when we don't treat individuals who have an early onset of attention deficit disorder, depression, anxiety, and substance abuse, that over the course of their lifespan, they end up having lower earnings and less income, and that's especially true among women. So these are a few of the examples of some real direct links between mental health and economics. Another area is when you think about the impact of those who have mental illnesses and their impact on the workforce. If we have about $41 million US adults having a mental illness, then that's a lot of people who have the potential to be working below their optimal performance and to be calling in sick, not being able to perform at their level of employment that they're being expected to. So one study found that mental health conditions were associated with $193.2 billion in lost earnings per year. That was in 2012 or 2002. When you adjust that money for 2013 dollars, you see that that's about $267 billion in lost earnings because of mental health conditions, which is roughly equivalent to what large corporations like Walmart and Exxon are bringing in their earnings each year. Talking about the expenses associated with a failure to address mental illness is one way to catch policymakers' attention. Here's a great graphic that shows you how the rising cost of interventions becomes as individuals get older and the interventions get more and more serious. So some interventions that can be delivered in the school, such as the good behavior game, relatively cheap. Cognitive behavioral therapy for anxiety, still relatively inexpensive, but when you get to intensive home-based therapy or inpatient hospitalization, the expenses are getting more. And ultimately, for our large portion of youth who have a mental health issue that end up incarcerated, then that becomes a very big expense on society. This graphic is from Mental Health America. You'll remember Mental Health America is an organization that grew out of the work of Clifford Beers and his advocacy efforts. So Clifford Beers and the book that he wrote after being institutionalized himself has had a really long-term, ongoing advocacy impact. When you're looking at the politics behind policymaking, one of the things that's important to consider is how is the social problem being addressed, and how did it come into light? Like, what brought the issue to the attention of policymakers? Unfortunately, in the mental illness and mental health care field, we find that a lot of the way the attention comes to be um, is that there is a horrible tragedy, as we discussed in one of the earlier videos. And so if that's going to be a different approach, if we're responding to a tragedy that was a one-time or a couple times incident versus trying to fix a broken system. So a lot of the proposals that are developed for remedying different situations are formulated in response to a tragedy. One area that is a sub-advocacy effort area of the broader mental health perspective is that of rural mental health advocacy. And in 2004, the new Freedom Commission on Mental Health found that the prevalence and incidence of mental illness is not different in rural versus urban areas, but accessibility, availability, and acceptability are. One exception to that is that suicide rates are higher in rural areas, according to this 1999 study. So when we think about accessibility, availability, and acceptability, what we're talking about is accessibility. Is there public transportation available so that I can get to and from my appointments? Are providers in my community available, and do they have the specialized training that I need to address my mental health issue? And acceptability. If I go to services, are people going to still treat me fairly within my own community? A lot of the community mental health policies that are created are founded on an urban model. So there's an assumption that there's going to be some social infrastructure within that community that is able to support that community mental health facility being successful. When we apply those same successful urban community mental health models to a rural environment, we find that they don't always succeed. And that's, as the first statistic on this slide shared, it's not because the prevalence and incidence rates are necessarily different in rural areas, but it's due to these other factors. One being that rural clients tend to enter treatment later. They have more serious and persistent symptoms by the time they arrive to treatment. And so at that stage, then they're going to require more expensive and intensive care. In rural North Carolina, a common entry point for mental health care is not through the counselor's office, but it's through the emergency department. So by the time someone has been facing a mental health issue and it's gotten to the point where it needs emergency department treatment and focus, that's been that something has escalated. And part of the reason why some members of rural communities are less likely to seek treatment earlier on is because there is a strong sense of self-reliance in a lot of rural communities, wanting to be able to solve problems for oneself and not be dependent on others. Poverty is another major issue in rural communities, and this map here shows how there are some differences in how poverty is distributed across our country. So we have a lot of the blue where there's very low poverty in the northern half of our country, and a lot of the red shading in the southern half of our country, and those are the areas where there would be extreme poverty. If you take a look at where UNCP is located, you're going to find us right here in this little corner of North Carolina, right on the border with South Carolina, and you'll see that there is a lot of the first three categories of concentrated poverty. So any community mental health initiative that's going to roll out here is going to look a lot different than if it was rolled out in Raleigh, because the differences in these rural and impoverished community here. When you have a policy that goes into effect, there might be a new treatment intervention or protocol, new type of services offered. There is a sequence of activities that happens. It's not so quick. There's stages, and you want to think about how you can do each of these stages very, very well so that the policy ends up being successful. It's a good idea to think that every public policy that gets developed is an experiment that needs to be tracked. So we want to look at outcomes with our policies. If you're going to be doing advocacy work at the policy level, then it's a good idea to keep in mind what do you want to see as a result of this policy getting implemented? How will you know that it has been effective, and how are you defining effectiveness? Effectiveness could mean that you are providing treatment to a greater number of people, or it could mean that you're reducing rates of suicide, but you want to know in advance what you're hoping to see. When we think about interventions that will work in poverty areas where there's a high concentration of poverty, we need to keep in mind that a lot of clients in poverty have tended to be over-pathologized. They work with less experienced providers, and they have higher rates of crisis management services and then lower rates of ongoing counseling. So our interventions need to have that in mind. Sometimes people think that addressing poverty is a matter of putting cash into the hands of people who are in poverty, and what this survey that was posted here in the Lancet in 2007 found was that the mental health interventions were associated with improved economic outcomes, more so than the cash transfers or asset promotions. So when we work with people to help improve their mental health, then there is a improved economic outcome associated with that. But when we give people a cash transfer, there's not necessarily going to be that same improved economic outcome as there was when we were providing the mental health intervention. As we move forward, we need to think about a couple of things on the policy, on the social national policy front, and that's over the years, as you recall from the survey that compared rates about stigma from the 90s to the 2000s, that there's this increased focus on neuroscience, and that's good because we're getting to know more about the biological basis of mental illness, but we also need to keep a focus on the social and emotional issues that impact mental illness too, because we don't want people to feel hopeless and that they're victims of their DNA or the way their brain functions, and that there's nothing they can do about it, because relationships actually are very important. They serve both a protective and a preventive function for all mental illness. So the things we advocate for need to focus on relationships and developing competency in the people that we serve. Another thing to keep in mind when you're advocating, and this would go at all levels, is that we can't wait until we have all the answers to get started. We have to start advocating right now, even while things maybe seem murky or messy, or maybe you don't feel like you're as much of an expert as you'd like to be. We have to also make sure that we're promoting wellness and not just responding to illness. That's one of the things I really like about counseling, is that we do focus on promoting wellness and not just targeting treatment for mental illness. We need to really emphasize children, because growing up in a safe and nurturing environment can have a great impact on future outcomes. We need to work on people's ability to handle stress and to recover from stressful events, and we need to make sure that we're giving lots of attention to trauma. Those are some things that we need to focus on as we move forward. And for you, and you think about the work that you want to do, you need to have a vision, and things are going to be hard. But if you have a vision, if you can dream big and think about how you'd like to change mental health care and counseling, then go for it. And don't avoid doing it because it might be hard, but do it exactly because it is hard, to kind of tailor John F. Kennedy Jr.'s quote about going to the moon. We choose to go to the moon not because it is easy, but because it is hard. Quote I want to leave you with here, or a message to leave you with here, is that there are a lot of challenges in the system of mental health care, and as a counselor and working with those who are mentally ill, but we can overcome these challenges. And to get good at anything, you have to be bad at it first and get incrementally better. So to be successful as a counselor, you need to have passion, you need to do the work, pick your focus, keep persisting, have lots of ideas, do good work, push yourself and others to do better, and make sure that you serve and give back to those who have helped to support you.